Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, die Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, MARKUS at Home welcomes Professor Barry Borlaug in Rochester, Minnesota, in order to discuss the SUMMIT trial on the use of the GLP-1 receptor dual agonist, Tirzepatide, in patients with obesity-associated heart failure with preserved ejection fraction, which has been elected the most important study in cardiology and lipidology 2024 by MARKUS at Home. Barry, we are honored to host you tonight.
Thank you very much. It's nice to be here with you.
Also from my side, very warm welcome, and thank you so much for being here. I don't think when we talk about heart failure with mildly reduced preserved ejection fraction, Professor Borlaug needs a lot of introduction. Anyway, he's one of the most highly cited scientists in that field and has been working on the special focus for years. He's clinically a cardiologist at the Mayo Clinic in Rochester, and he has a education also at the Brigham and Women's, and worked at the Johns Hopkins University together with our co-moderator, Professor Christoph Maack from Würzburg, who's at the German Heart Failure Center there. And we're also delighted, Christoph, and honored to have you here to share the discussion. We'll be talking about the SUMMIT trial, Tirzepatide and HFpEF, and obviously we also want a glimpse into your ideas on HFpEF diagnosis and mechanisms, which you're a true expert in. So, Barry, if you could first share some slides on the trial, and we're really looking forward to your presentation. Thank you already.
Great. Well, just some basic background here that I think most of you are aware, but heart failure with preserved ejection fraction, we've said for years it's half of all heart failure. It's actually overtaking heart failure with reduced ejection fraction. In more recent looks, it's even more common. The incidence and prevalence are increasing over time. The risk is similar in men and women, but women live longer than men, and women live longer than men once they have the diagnosis of HFpEF. So when you look cross-sectionally, about 2/3 of patients with HFpEF are women. And outcomes are very poor. Now, we know that HFpEF is not a simple homogeneous disease. It's a heterogeneous syndrome. And this is a study where we categorized patients with HFpEF into these different pathophysiologic phenotypes. And you can see the size of these boxes is roughly proportional to what proportion of all patients with HFpEF have this phenotype. And then the overlap between these boxes indicates that the overlap between phenotypes. So you can see that lots of people have many of these different phenotypic traits. Some of them just have one. But by far the most common phenotype is this cardiometabolic phenotype, which is about 3/4 of patients with HFpEF. And 95% of those people have obesity. So when you look at the US, between 60 and 70% of patients with HFpEF have obesity, or this obesity-related phenotype. I know in Europe, the obesity epidemic is not quite as bad, but I believe that there's also a substantial contribution in Europe as well. Now, people with obesity-related HFpEF have many of the same things that non-obese HFpEF patients have, such as diastolic dysfunction, but there are some specific pathophysiologic components which are a little different. They have a marked increase in visceral adipose tissue, shown here, which is pro-inflammatory, causes insulin resistance associated with worse hemodynamics. They have more severe inflammation. They have higher CRP levels. They have more volume expansion. You can see here blood volume versus body mass index in men and women really strikingly goes up. They have an increase in pericardiac fat around the heart, coupled with increases in left ventricular mass, and hypertrophy leads to increased extrinsic restraint on the heart from the pericardium that further pressurizes the heart and makes the filling pressures worse. When you do biopsies and take the heart cells out and look at their developed tension, when you incubate with calcium, the maximal developed tension is lower in patients with obesity, so they have even systolic impairments. They have lower myocardial efficiency. They have more age-related stiffening. They have greater abnormalities in venous capacitance. All of these things lead to HFpEF. It's not just one. It's the combination of all of these things. But fundamentally, all of these abnormalities are directly related to the amount of excess body fat. suggesting that if you get rid of the fat, you can potentially treat all of these different components. Now, tirzepatide is a dual incretin. It's a dual GIP, GLP-1 receptor agonist. And it's been shown in SURMOUNT and other trials to lead to pretty dramatic weight loss in people with obesity. So that was the background, the rationale for the SUMMIT trial, which we presented at the AHA just a few months ago and was simultaneously published in the New England Journal. Milton was the lead author and steering committee chairman for this trial. These were the eligibility criteria: patients with heart failure, preserved EF, real HFpEF, EF 50%. So it's not one of these trials where it's 40 or 45. It's true HFpEF. And they had to have obesity, BMI 30 or greater. They had to have objective evidence of HFpEF, either LA enlargement, high filling pressures, or elevated natriuretic peptides. In addition, they had to have an objective impairment in exercise capacity and heart failure severity by symptom score, KCCQ, Kansas City Cardiomyopathy Score. And as an additional enrichment criterion, they had to have either heart failure hospitalization in the preceding year, or they had to have CKD. Just to increase the risk of people that would have events. And patients were randomized double-blind 1-to-1 to treatment with placebo or tirzepatide, starting at 2.5 milligrams, titrated up to a goal dose of 15 milligrams once weekly. This was achieved over a 20-week period. All patients completed at least 15 weeks of treatment. Double-blind treatment was continued for up to 3 years. The median duration of follow-up was 2 years. The trial was stopped when the last patient enrolled completed the 52-week visit. The original primary endpoints, when we first designed this, a 700-patient trial, we didn't think that that would be enough to detect an effect on heart failure events. So we set it as a composite of heart failure events or cardiovascular death, and KCCQ score, patient-reported symptom severity, and exercise capacity, analyzed using as a hierarchical composite using the win ratio. And these were the initial projections for that. But then at ESC in 2023, the STEP-HFpEF results were presented, which I think probably most people are aware of, showing a marked reduction in the risk of worsening heart failure events, low number of events, but a very impressive effect size. Now, in STEP-HFpEF, this was an exploratory endpoint, but still it was very provocative. So before seeing any of the data, and when the steering committee was completely blinded and only after consultation with the FDA, we changed the primary endpoint from the composite win ratio-based hierarchical composite to cardiovascular death or worsening heart failure. And the co-primary endpoint was KCCQ score. And this was the alpha allocation was 0.04 to the hard outcomes, then 0.01 to KCCQ. All events were adjudicated by a blinded clinical events committee. We defined worsening heart failure by either hospitalization for heart failure, need for IV diuretics as an outpatient, or oral diuretic intensification for the purpose of heart failure. Not just any increase in diuretics, but it had to be a specific deliberate increase in oral diuretics for worsening heart failure. The trial was sponsored by Eli Lilly. This is the disposition. 731 patients were randomized. About 80% completed the study on treatment, missing vital status in only a small number of patients. These are the baseline characteristics. Excellent female representation, much higher than most other outcome trials in the HFpEF space. Over half of the patients were women. You'll note that the NT-proBNP levels were not elevated. The median NT-proBNP in this trial was only 175. This is in striking contrast to all of the other recent outcome trials in HFpEF, where an elevated NT-proBNP value was required for enrollment, usually either 200 or 300 in sinus rhythm. Here we did not require that. And this is important because that's patients with obesity-related HFpEF have much lower NT-proBNP levels. They had significant CKD. You can see the estimated GFR, 64. They had severe heart failure, a KCCQ score of 53. So this ranges from 0 to 100, lower is a worse score. So this is a very poor score. Severe impairment in exercise capacity with a baseline 6-minute walk distance of just over 300 meters. And almost half of the patients had had a heart failure hospitalization in the preceding months. They had very high CRP levels. Well over half of them, I think about 2/3 of them, had an elevated CRP level. So here's the Kaplan-Meier curve for the risk of worsening heart failure or cardiovascular death in the placebo group, affecting 15.3% of all patients, an event rate of 8.8 per 100 patient years. As compared to placebo, Tirzepatide reduced the risk of worsening heart failure by 38%. And that was statistically significant. If you remove the oral diuretic intensification, the effect persists. If you look only at heart failure hospitalization or IV diuretic use, it again becomes even stronger, closer to a 60% reduction. Here's the other dual primary endpoint, the change in KCCQ score, also highly significant, 7-point improvement as compared to placebo with Tirzepatide. So it met on both the primary and secondary endpoints of the trial, both of the dual primary endpoints, excuse me. And this was very highly consistently observed across all of the different pre-specified subgroups of interest, different categories of obesity, younger versus older, men versus women, higher versus lower BNP. None of these really stuck out as being a significant difference. Key secondary endpoint was the change in 6-minute hall walk distance, which also was significantly improved compared to placebo, 18-meter improvement, similar to what was observed in STEP HFpEF with semaglutide. Subsequent to this, a couple of days later, we published this paper, which was an expanded evaluation of all of the endpoints, and I'm just going to run through a couple of those because you can't go through all of this in the main New England Journal paper. There's just not enough word count. But we looked at all of the other outcomes that were sort of related to the primary endpoint, and you can see no matter how you define this, whether it's CV death or worsening heart failure, excluding oral diuretics, 43% reduction, cardiovascular death or worsening heart failure, excluding diuretics, 48%, any worsening heart failure event, 46% reduction. It was very consistent. Everything was favoring Tirzepatide. All of the whiskers were to the left of unity, as you can see here. This is a different metric, the EQ5D5L, which is notoriously difficult to improve with any heart failure treatment, and it was very significantly improved. Some independent measure of health status to the KCCQ score, also significantly improved. This is the patient global impression, which is just asking patients, do you feel the same, better, or worse? And you can see that the likelihood of feeling better was substantially greater at both 24 weeks and 52 weeks, twofold greater odds of achieving that favorable response. This is NYHA class, also greater improvement with Tirzepatide as compared to placebo. And then this is use of heart failure drugs. So after randomization, there were fewer heart failure drug increases and more heart failure drug decreases in the group treated with Tirzepatide compared to placebo, and this was mostly driven by diuretics. So people who got placebo were more likely to have an increase in diuretics during the conduct of the trial, and the patients receiving Tirzepatide were less likely to have an increase, and in fact more likely to have a decrease in diuretics, which very much complements the findings with the reduction in heart failure events. These are the safety data. They're similar to other trials with incretins. There was a lower rate, as you would expect, of heart failure events. There were more GI intolerance. There was more diarrhea, nausea, constipation. This is all very well known with incretin drugs. GI symptoms led to discontinuation, though, in only 4% of the Tirzepatide group. So for the majority of patients, they were able to tolerate this. So here's the conclusions from the main trial. This is the first trial in patients with HFpEF and obesity where we saw a reduction in heart failure outcomes as the primary pre-specified endpoint of the trial. It was a significant 38% reduction. It was not determined by oral diuretic intensification. It was still significant even if you don't include that component. There were improvements in health status, exercise tolerance, quality of life, functional class, and every different component that we looked at, all these different orthogonal indices of heart failure severity. And then the safety profile was consistent with what we've seen in other trials with tirzepatide. Now, before I open it up discussion, I want to just go a little bit into the mechanistic analysis. So this was published one day after we've published the primary results in the New England Journal. This was also presented at the AHA. So we know that it's working for all of these reasons, but why? And this is what we see in patients with obesity-related HFpEF. They have stiff blood vessels. They have hypertension, and they really get a dynamic hypertensive response to exercise. They also have more volume expansion, and people with obesity-related HFpEF have a greater increase in LA pressures as their plasma volume increases. We don't see that in non-obese patients. They have more severe inflammation. They have more increases in visceral adipose tissue, which contributes to both the volume overload and the inflammation. They have evidence of myocardial injury. So troponin levels, which we know we usually think about looking for acute coronary syndromes, but we know that in many patients with chronic heart failure, there's evidence of myocardial injury that's present in about 40% of patients with HFpEF. And those with a detectable troponin level have worse hemodynamics. They have higher filling pressures, both at rest and exercise. They have more severe cardiac dysfunction. They have more impairment in exercise capacity. We also know that CKD is a big deal in HFpEF. And in fact, when you compare people with obesity-related HFpEF to age, sex, and obesity-matched controls without heart failure, one of the strongest differentiators is whether they have CKD or not. So whether it's their ability to regulate volume status or other factors unknown, but it's clearly an important component of the disease. So I showed you this earlier. We know that heart failure events were reduced. We know that symptoms got better, but why? And why did the 6-minute walk distance get better? So that's what we explored in this analysis. We determined the effects of tirzepatide as compared to placebo on volume expansion, circulatory pressure overload or hypertension, and systemic inflammation. So we assessed blood pressure at the study visits. We estimated blood and plasma volume using the Hakim formula and a way to estimate blood volume and plasma volume. And we measured systemic inflammation by CRP levels. And then we determined the effects of tirzepatide as compared to placebo on end organ function. So these are the hemodynamic circulatory changes. These are the effects on the heart and kidneys. So we looked at kidney function, estimated GFR. We used both the cystatin C and creatinine-based GFR. We looked at albuminuria. We looked at myocardial injury by troponin T, and then myocardial stress by NT-proBNP levels. And then finally, we looked for relationships between the changes in circulatory pressure and volume and the changes in cardiac function and structure and kidney function. I'm going to skip over this because we already went over the baseline characteristics and get into what we saw. So this is the change in systolic blood pressure in the placebo group at each of the different study visits, as you can see. This is what we observed in the tirzepatide group. Even after just 4 weeks of treatment, way before the maximal weight loss effect, there was a highly significant decrease in blood pressure, which continued to increase out to 24 weeks and then sort of leveled off and was maintained throughout the study. So there was a marked reduction in pressure overload. And there was also a reduction in volume overload. So now here is the change in estimated blood volume using the Hakim formula. And you can see that it was significantly reduced after just 12 weeks and that this increased throughout the course of the trial. All of these were very highly significant. This is the change in CRP. At 12 weeks, there was no significant effect. At 24 weeks, we finally start to see a statistically significant reduction in CRP. And then by 52 weeks, about a 40% decrease in systemic inflammation measured by CRP. This is the change in cardiac injury, troponin. At 12 weeks, no effect. But at 24 and 52 weeks, even though these patients didn't have marked elevation in troponin levels, there was a statistically significant 10% decrease in troponin levels. And there was also a roughly 10% decrease in NT-proBNP levels. Again, even though the baseline NT-proBNP values were fairly normal, 175 was the median. Kidney function. So this is what we saw at 12 weeks. There tended to be a worsening of estimated GFR. And in fact, when you use GFR based on creatinine, that statistically was worsened by tirzepatide. This is similar to what's been reported with semaglutide as well in the FLOW trial. At 24 weeks, however, this was starting to reverse. Now there was no effect. And at 52 weeks, as compared to placebo, there was an improvement in estimated GFR. And this was consistent with whichever formula was used to estimate GFR. This was complemented by a significant reduction in albuminuria, about a 25% decrease at 24 weeks and a somewhat lesser increase at 52 weeks. So more objective evidence of favorable effects at both the heart and the kidneys. Now, the decreases in blood volume were correlated with the drop in blood pressure, with the decrease in albuminuria, with the improvement in quality of life scores, and with the improvement in exercise capacity. When we looked at the changes in CRP on treatment, those were correlated with the decrease in cardiac injury and the improvement in 6-minute walk distance, tying together the volume overload and the inflammation with the clinical effects that we see in these patients. So from this last mechanistic analysis, we conclude the treatment with the tirzepatide for 52 weeks reduces circulatory volume and pressure overload and inflammation as compared to placebo. And these effects are then coupled with favorable mitigation of end organ damage in both the heart and the kidneys. And this may provide new insights into why why tirzepatide and potentially other medicines of this class might be so helpful in people with obesity-related HFpEF. So that's all I have. I'm happy to open it up. I'll stop my share so we can discuss.
Thank you so much, Barry, for this presentation. And I mean, these data are just awesome. And then we knew most of them, but the insights are great. And we're really looking forward to some discussion if you spare the time. I want to ask just a quick question before leaving the floor to our experts, Markus Säemann and also Christoph. The whole weight loss issue has been debated, obviously, also with semaglutide. And what I'm wondering is, what do you think? You mentioned that some of the effects occurred earlier than the weight loss. So what do you think? What about lean people? I mean, you said 2/3 is obesity, but what about people like you and me who might get HFpEF because they're diabetic, because and would they tolerate the substance? Because I do see patients in clinical practice that lose too much weight and they wanted to stop with GLP-1 agonists. And would the mechanisms be similar? What's your thoughts on that?
I think that's a really important question that needs to be addressed in trials. I mean, remember, people that are, with a BMI over 25, that's still overweight, and they still have excess body fat. They could still be helped by these drugs, by whether it's tirzepatide or other incretins. So I think that needs to be tested. Another group, particularly people in Asia, where a high BMI is very low, but they often have increases in visceral fat, that abdominal visceral fat. Those people might also be improved. So I think that it's not necessarily restricted to people with obesity. Now, whether you can go too far, that's another good question, and we don't know that. We didn't see that. We didn't, with these drugs, you don't usually see people going from a BMI of 35 down to 21. They're just not that powerful. But we have seen people that, have complained, like, I feel a little bit more weak. And we know that not all the weight lost is fat. Of course, some of it's muscle too. And so that's another important item to chase up in further studies, whether we can add drugs or other interventions like resistance training to prevent some of the skeletal muscle loss, I think.
Yeah, thank you, Professor Borlaug, for your fantastic talk, because you summarized in a short time this complex field. So I remember that only a few years ago, HFpEF was some kind of a graveyard for pharmacy because nothing worked, so to say. And now we have 3 different kind of substances that work. So with the totality of evidence and your understanding, what would be the root cause to address for the future? Because you said fat accumulation, cardiometabolic health. I think previously we maybe wrongly thought it's a functional problem with, failing angiotensin inhibition and so on. So is it insulin resistance that is the root cause of this problem? Or is it maybe fluid overload that goes separately and we should focus on more reduction of volume or fluid overload together with cardiometabolic health? So will every kind of decrease of insulin resistance work?
Well, I think thank you. That's a good question. It really gets at the heart of the matter. And I think that, we should almost use different terms for people with this more cardiometabolic HFpEF from the other sort of non-obese, non-cardiometabolic HFpEF. That kind of HFpEF, which is about a third of patients, at least in the US, maybe a little bit higher in Europe, those are the people with more of the classical, they're older age, they have a long history of hypertension, they have stiff vasculature, they frequently have atrial fibrillation, pulmonary hypertension, tricuspid regurgitation, things like that. That group, they're helped by SGLT2 inhibitors too, but they're not really addressed by by the incretins, I think, or as far as we know so far. But the larger group with the cardiometabolic, I think that's why we now have all of these drugs, because we know that targeting those pathways that are involved in, that are deregulated or upregulated with obesity and this excess fuel, basically, that's really important. And what's it treating? Is it the volume overload? Is it the cardiac dysfunction? We don't totally know yet. It's probably several of many things. We published a trial called the Cameo DAPA trial in Circulation about a year and a half ago. This was an SGLT2 trial. It was only 37 patients, but it was invasive hemodynamic exercise endpoints. So it was a very sophisticated and detailed sort of assessment for the endpoint. And we saw that as compared to placebo, treatment with dapagliflozin for 6 months reduced LA pressure at rest and exercise by about 20%. So that was interesting. 70% of those patients were obese. And when we looked deeper, we actually did some additional assessments. We did DEXA scans to look at body composition. They mostly lost fat. It was mostly this upper body android fat. And that was correlated with the degree of improvement in the hemodynamics, suggesting that there's an important crosstalk here between these different things. We also saw, we looked at, so we know people with HFpEF often have exertional hypertension. So when they exercise, their blood pressure at rest may be 150, but it goes up to like 240 with exercise. We saw that dapagliflozin compared to placebo reduced exercise blood pressure by like 20 millimeters of mercury. It was a pretty massive effect. And we looked deeper with more sophisticated assessments of aortic stiffness. And we actually saw that it improved total arterial compliance during exercise and reduced characteristic impedance. So it's having vascular effects. It's de-stiffening the aorta. In addition to that, I mentioned earlier that there's abnormalities in venous capacitance in these patients. So their veins are constricted, squeezing more blood into the central circulation. You can measure that by what's called the stress blood volume. And in that same study, which was also published in Circulation last year, we saw that there was a reduction in the stress blood volume. So it's improving venous compliance, arterial compliance. It's causing LV mass regression. It's reducing volume overload. It's doing so many different things that are like really at the heart of what HFpEF is. So I think that's why these drugs are so incredibly effective.
Mm-hmm. And maybe one maybe exaggerating question, because some of us are also nephrologists. Can CKD itself be simplistically regarded as a overall HFpEF, because they share all the features like atrial fibrillation, increased pulmonary blood pressure, and so on?
Yeah, it's really funny. It's kind of what you have is what kind of doctor you go see. So the patient might come to see me and I say, oh, you have HFpEF. And they may go to a nephrologist and they say, oh, you've got CKD. They may go to a hypertension expert and they say that you have hypertension. They go to an electrophysiologist, says, "Oh, you have atrial fibrillation."
Yeah. If you have a hammer, everything is a nail.
But I think all of these things are related to one another. So we can call it whatever we want. You know, the AHA wants to call it CKM syndrome now and stuff. It's a disease that is related to excess fuel and fat and inflammation, everything that comes from this that affects the heart, the kidneys, the blood vessels. And I think it is. It's, you know, really, in some ways, it doesn't matter as long as we all appreciate all of those different components. But I do think so. I think what you're saying is right. I think that in the cardiology world, when we say somebody has heart failure by taking them to the cath lab and putting catheters in and measuring the pressures inside their heart. And if they have symptoms and those pressures are high, we say that is heart failure, because that is. It fulfills our a priori definition of what it is. So if I take those CKD patients that you might have in clinic and I put the catheters in, and I see that, then I would call that HFpEF. Maybe the reason they have HFpEF in part is because of the CKD, because they can't, because of all the reasons, you know, the inflammation, profibrosis, volume regulation, etc.
Okay, because 15 years ago we said this, and then we want to publish it with, you know, dialysis patients, which are the most severe in this regard. Everybody laughed at us because they did not fulfill the criteria. It was even called HFnEF, as you may remember. A lot of them disregarded that this disease really exists, especially the interventionists in the cardiology fields. Now we have a different scene. Okay, thank you.
Yeah, you bet. Thank you.
Before Christoph takes over, I have one clinical question, one speculation actually. Do you believe this is the end of the field of incretin agonists, or may we expect even more with the upcoming even triple agonists or some other dual agonists that work upon other incretins? And maybe in the same line a little bit, there was slight increase in mortality in some. Truly, it was not significant and very low numbers. But might this point to maybe some safety signal that has to be studied more in detail, or this is just play of chance?
Well, I'll take that last part first. I mean, I think it's probably just play of chance. I mean, for cardiovascular deaths, we're talking about 8 versus 5. So very, very low numbers and could easily be explained by play of chance. So you know, Tirzepatide has been studied in other populations with high CV risk, and there's never been an observation of an excess risk of cardiovascular death. Same thing with semaglutide. I know that's a different compound. It lacks the GIP, but still, I think that until something proves otherwise, I wouldn't consider that to be a significant concern. I would say that this is not the end. It's just the beginning, because you know, the drugs that are coming down the pike are much stronger, as you point out. The dual, triple incretins, they lead to, instead of a 10% body weight reduction, it's more like a 20-25% body weight reduction. And whenever we've looked, there's a direct correlation between the magnitude of improvement and the amount of body weight lost. So, you know, for every 10% body weight reduction, you have, let's say, a 12-meter improvement in 6-minute walk distance. Suggests that if you can lose 20%, you know, provided you have that much excess body weight, you're going to do even better. And there are plenty of trials that are coming that are going to test these more potent drugs.
I would also dare to, Christoph, before you go further, ask a very basic and clinical question. From your work as a clinician, we talked about the mechanisms, the way the pro-BNP wasn't elevated in SUMMIT, the fact that dialysis patients have obviously very high BNP. What's your ideas on an easy, if that's possible at all, easy recognition or diagnosis of these patients? I mean, we know we can take them to the cath lab, do exercise tests and right heart catheterizations, but at least in Germany, that's very uncommonly done, very seldomly done. And I put them on the bicycle test and do some echo parameters, but even that's rarely done. What's an easy diagnosis if that exists at all?
Well, there are these different scores. There's a score that we came up with called the HFpEF score, H2 HFpEF score, and this was validated based on people where we had characterized whether they have HFpEF or not HFpEF based on the invasive gold standard, invasive exercise testing, and it's 4 clinical criteria and 2 echoes. So if your age is 60 or above, if that's 1 point, hypertension with 2 or more antihypertensives is a point, age above 60 is a point, obese is 2 points, atrial fibrillation history is 3 points. And then there's 2 echo Doppler, high EE prime ratio and high RVSP. And it ranges from 0 to 9. If the score is 6 or higher, we've shown repeatedly it's 95% probability that you have HFpEF. So I think that if they fulfill that criteria, you're done. If they have 0 points, it's not. If they have 1 point, it probably isn't, but it still could be. If it's 2 to 5, that's when you really probably should be doing more evaluation. And so that's the HFpEF score. There was also, about a year after we published that paper, there was the HFpEF score, which is consensus guideline. It's not based on data. It's based on expert consensus. But it's similar. It's got points that range from 0 to 6, and 5 or 6 were deemed to be rule in. 1 or 2 is rule out. 3 or 4 is like intermediate. And that also works. It doesn't work quite as well. They've been compared head to head. But it has a very good positive predict value. So if the score is high, if it's 5 or 6, that is usually HFpEF. And then more recently, we came up with another one called the HFpEF ABA score, which is based on a logistic model. It doesn't need the echo. So it's just age, your BMI, and whether you have atrial fibrillation. And you can spit out a probability of whether you have HFpEF. And when we've looked at that, if it's above 90%, it's almost certain that the patient has HFpEF. So we can use these to get closer, but I still think that those intermediate patients, it's on us as physicians. We need to come to the diagnosis. We need to do invasive testing more frequently. We do it if somebody has crushing substernal chest discomfort, we don't say, oh, it's too much. It's too much to do an angiogram. It's just, of course not. We wouldn't do that. So why would we do that for heart failure? Why would we say we're not going to do it because it's too invasive? We're cardiologists. We do invasive things all the time. So I think we should do it more commonly. Exercise echo has problems with sensitivity, but I think that we'll get better with that with time. And that's obviously preferable because it's less invasive, might be, less costly and things like that. But we still have to define the role for that a little bit better. Sorry to go on and on. This is kind of a big issue with me.
Highly relevant. Thank you. Very good information for us.
Yeah, Barry, thanks for having this really excellent presentation. And I must really confess, I'm a big fan of your work. And in previous meetings with Gunnar and Stephan, we have already several times discussed HFpEF. And the more they challenge me on the question, the more I dig into your work and find the answers to it. So to put this up front. So for a long time, I've been, mainly focused on this idea of afterload increase. And I think we discussed this also on some of the boards we've been on. So, the heart, it has its own compensatory mechanisms to work against changes in load. And a long time I've been focused on this afterload thing, which is obviously induced by hypertension and the age-induced stiffening of the vessels and ventricular arterial coupling. But now with this obesity, with a shift focus on obesity, and you've explained it nicely, the preload or the preload component adds to it now very substantially. And it looks like, I know that these obese patients, if you look at Dave Kers's data from the biopsies, they have alterations on the sarcomeric and mitochondrial architecture, and there's certainly some damage. But we could explain many of the things just by the load. And because it's known, and that was an eye-opener to me, that the patients with HFpEF at baseline have nearly twice as high oxygen consumption than patients, especially those that have some hypertrophy as well. And that means that these compensatory mechanisms for the high afterload, which is the unrep effect, and the preload, which is the Frank Starling, are both energy consuming. And this puts the heart into the situation of exploiting its reserve, so that when they now then undergo exercise, there is no reserve anymore. And this was now an eye-opener to me, as I saw also your Nature Medicine paper with the blood volume. And I went back to your 2017 paper where you already described the obesity phenotype, and it was all rare. So the wedge pressure correlates with the amount of blood volume and explains why the preload is already to some extent exploited as well. So having seen all this, do you still think that HFpEF is a diastolic problem? Or in other words, or maybe the easier question first is this sufficient to explain the phenotype? Or
No.
do you need additional components like the inflammation and the cellular changes that we see, or is this already sufficient?
Well, that's a really tough question, I think. It's more of a thought question because you'd never be able to really test it in a reductionist way. But yeah, I mean, it's a really good point. The combined pressure volume overload in and of itself is should be enough to cause cardiac failure in a lot of patients. But all of these other things probably also contribute. And when we've looked at people who have more severe inflammation, they do have some differences, some problems with like peripheral oxygen uptake in skeletal muscle and things like that. We're just starting to scratch the surface with that. We think that those people get more interstitial fibrosis related to that long-term sort of sterile inflammation. So that might affect the properties of the interstitial matrix, in the cardiac myocardium and elsewhere. So my guess is it's the that does play a role, but to exact extent, how much of a role, unclear. We'll know more when the Hermes trial results are presented and published. So Hermes is a trial testing the anti-IL-6 antibodies ziltivekimab. And it's an outcome trial in HFpEF that's currently active. And that one is not target unless some of the afterload or preload is related to inflammation, which I doubt, but unless it somehow is, that's going to really test the hypothesis, just getting rid of the inflammation. How much does that help? That would be really informative. With the incretins, it's so dirty because these things are doing they're very promiscuous. They're doing inflammation, they're doing volume load, they're doing pressure load, they're causing regression of LV hypertrophy. And as you say, so I didn't go through the MRI sub-study of Summit, but we did do an MRI sub-study, and there was a regression of LV mass, which was the primary endpoint for that. And there were signals. There was a trend for a decrease in LV volume too. So it is probably a combination of both the pressure and the volume. And then the other thing is these people often have myocardial steatosis. Now, it's not quite like fatty liver. It's not like that degree, but they do have quantifiable increases in intramyocardial fat, and that may also play a role. So that might also be something that we need to be thinking about with weight loss.
I agree. I mean, it was very provocative. I mean, the hemodynamics is one thing, but we also know when we just look at the cardiac myocytes that of models of HFpEF, or in the case of the study you've shown by Dave Cass, that sarcomeric function is altered. I mean, you emphasize this decrease in the maximal force generation. However, this is at very high calcium concentrations, which are never reached in the cell. And the lower part, which you don't see so much, but it's also in the paper, it's a leftward shift in the calcium affinity of the myofilaments. That means that in the normal calcium ranges, you get an earlier and stronger activation of the sarcomeres, which already consume more energy at the same calcium concentrations as the normal cells. And our research goes in a direction where this mismatch in energy supply and demand can induce oxidative stress, which can lead to a number of these remodeling processes that we see, like it could induce fibrosis, but also hypertrophy. And that maybe explains by taking away the strain where you see the reverse remodeling as well. So the kind of the maladaptive response to these hemodynamic alterations to some extent is mediated by these intracellular oxidative stress processes, but certainly also by the neuroendocrine aspects. Another thing I found intriguing in what I read in your paper is this role of adipocytokines. Is that the right word? Yeah. Right. So, I mean, you make the case that that these could be also the drivers of the volume overload, because the fat cells release these adipocytokines that lead to more sodium and water retention, and that fills up the vessels. Of course, the increase in fat mass also requires more blood volume to perfuse that all. But do you think this is the critical hub here, where I would say fat translates into hemodynamics?
Maybe.
I mean, the question is, why do with more fat you have these hemodynamic alterations in the first place? Is this the prime mediator?
I think that's part of it. I mean, so there's been studies. So there's leptin, there's aldosterone, and then there's pro-inflammatory cytokines like IL-6. So there have been studies where they've sampled blood in people undergoing surgery in the portal vein and then in like the radial artery. And there's a huge gradient in IL-6 indicating that it's originating from visceral adipose. Is secreting IL-6. And of course, IL-6 stimulates the liver to make CRP and cause inflammation. So to what extent inflammation is contributing, I think that the fat mass causing an increase in pro-inflammatory cytokines, definitely important. But then, leptin and aldosterone, they're very anti-natriuretic. I mean, they cause you to hold on to volume, and that probably does contribute to the volume overload. So if you already have a stiff heart, and then you have these increased epicardial fat and pericardial restraint, and you have constricted veins and stiff arteries, and now you've got increased volume because the kidneys are holding on. It's just the perfect storm. Obviously patients are going to have bad heart failure. So I think it's really important. I mean, the only way we could definitively test that is if we had like an anti-leptin drug or, something like that. And if we saw a benefit with that. We're going to look in Summit. We have a lot of blood banked, so we'll look at a lot of these neurohormonal, adipocytokines and neurohormonal biomarkers, and that'll help us learn a little bit more. But we still won't know completely. But I do think that it's probably a significant component, just like it is in HFrEF with the RAS system.
Yeah. So at the end of the day, I mean, that really nicely explains the systemic character of this disease and why it makes sense to formulate a cardiac, kidney, metabolic overall phenotype, or because the things are so tied together. But maybe, I mean, and I come back to my initial question, maybe HFpEF has long been reduced to a diastolic dysfunction. And in my view, the diastolic dysfunction, it may contribute to some of these factors hemodynamically when you go into exercise and where you are missing a little bit piece of ventricular filling. But I think it's the tip of the iceberg, because
I agree.
All these systolic or the load-dependent alterations and everything we discussed is at least equally, if not more important. And maybe our narrowed view onto a diastolic heart failure phenotype has made us use the wrong or test the wrong concepts for a long time, right? Because we were just focused on diastolic function, which we, by the way, cannot even measure it really well in echo. We're just looking at some correlative things here, which at the end of the day look at load, right? E by E prime is more or less LV-EDP. So it looks like we more and more understand now what is HFpEF. And I remember exactly like 10 years ago, Stephan was always laughing and saying, you cannot even define your disease, so you will never find a drug that will work against it. No? But now, I mean, we understand it now much better. And apparently we have hit the right nail now with our hammers. So it's a great and exciting time to follow cardiology now.
Speaking of therapy, because I have one question. What do you both think because so many companies are out there now having their own pipeline and testing the incretins, obviously, because there's a lot of money in the market, and we see next to the combined dual and triple agonists, we see approaches where we have a GLP-1 agonist and a GIP antagonist. And I, to be honest, get a little confused how you could at the same time have a beneficial effect with an antagonist and an agonist. That kind of underlines that we don't really understand the mechanisms, or do we just not get it correctly?
No, I think we're just scratching the surface. We know that these different combinations lead to different degrees of weight loss, but in terms of what else they're doing, it's an unknown. For example, there's a lot of GIP receptors in epicardial adipose tissue. That's one of the more dense areas where there's a lot of those receptors. What does that do? We don't know. So a lot more work needs to be done to better understand this, I think.
Maybe last question for me. Do you think it's the degree of weight loss, I mean, at the end of the day, or does GIP play an extra like signaling role in these processes? I mean, it's probably the same answer they just gave, right?
I can't, yeah, I refuse to speculate because I have no way of knowing. I mean, there was a little bit more weight loss with tirzepatide as compared to semaglutide. It's presumably related to the GIP component. We, presume because the GLP-1 is the same, but how that factors in is totally unclear. I'd really like to better understand that, I think.
I expected more nephrology questions from you guys about the role on the kidney, especially with the flow data. Is there data coming up is there a specific study on the dual agonists in the nephrology field? You presented the sub-analyses from Summit, but are there specific outcome trials planned?
Yes, with Tirzepatide, there's a specific kidney trial planned because we have this data on anti-albuminuric effects and GFR preserving effects. So we are waiting for this data.
Maybe I have another question, again, mechanistic, sorry, but it goes back to your Nature Medicine paper. I mean, you showed nicely that that very early on, blood pressure, blood volume, and NT-proBNP is going down. But CRP later and troponin T also later.
Yes.
I would have thought that the decrease in load, I mean, because when we do pressure overload in our mice, when we do this in the right animal model and the right strain, we do see necrosis by the afterload because we produce a lot of oxidative stress. So there is cell death. And so I would have thought that by unloading, and this seems to be an early process, that should be accounting for the troponin T decrease, but that's not the case. So why do you think is there a delay? And second question, do you think the troponin T is upstream of CRP? Meaning, I mean, if you have cellular damage, that is something that can trigger inflammation. So is that upstream that explains why the CRP response is also later?
Oh, that's an interesting thought. I guess I mean, all we have is sets of data at a couple time points, so we can only guess, of course.
Yeah.
But what my supposition is that the inflammation seems to be more strongly tied to the myocardial injury for some reason. And I've always thought that it was the inflammation affecting the heart. I guess what you say is possible too, that the reduction in myocyte loss could, if we were testing it every day, maybe we'd know which one comes first, precedes the other. But I suspect that there's maybe a certain amount of excess body fat that needs to be lost. Adipocytes need to shrink down to stop releasing IL-6 and then CRP at that rate, and that may be what's leading to the reduction in myocardial injury. That's just my guess, but it's interesting. The sequencing was definitely different between the load effects, whether it's blood pressure or blood volume or NT-proBNP. Those were all pretty early, but as you say, the inflammation and the myocyte necrosis were delayed. So it seems like there's two different things going on, or there's a threshold effect, like you need a certain amount of treatment, whether it's weight loss or whatever, to achieve that effect.
And interestingly, it looks like maybe the adipocytokine mediated blood volume effect precedes the actual weight loss.
Yes.
Is that right? I mean,
yeah, well, people start losing weight pretty early, but I mean, you've got to remember that these medicines also they decreased appetite and they increase satiety. So people start, they stop taking in as much food and drink pretty early. So some of it may just be related to that. It's kind of like what happened in COVID when people, heart failure, worsening heart failure went down during COVID. And it's probably because people were staying home, not going out to eat and having a bunch of salt and stuff, and that made their heart failure better, because they were taking in less. So I think that's probably part of it too.
Maybe just one, not a nephrological, but a clinical aspect. One final word for me. My impression in our patients is they eat definitely less, and they eat particularly less unhealthy food and rather switch to more healthy food. There are good data that people drink less alcohol and smoke less cigarettes.
Yeah. These drugs are really interesting. They definitely, I mean, they're working in the brain in large part, and they're taking away a lot of those cravings for both alcohol, but also for other illicit drugs and things like that. And then, when nausea and vomiting are so common, and so we're doing another trial right now with semaglutide here. So we're dealing with this all the time with the patients calling in, and they call in like, oh, I'm having all this nausea. Like, well, what are you eating? And they're eating, pizza and cheese and all this stuff. Well, eat less fatty foods and have smaller portions, and your nausea will go away. And then they do that, and then the nausea goes away. So it's kind of that's how it's working. That's the whole idea. So if you eat more fatty, they're doing that because it's adaptive, because they don't want to, just like a mouse that's getting buzzed by some blockade or something like that. They're like, oh, this causes nausea, I'm going to stop eating this. It just turns out that's exactly what they should be doing.
So in other words, I mean, prevention is so important. I mean, the situation we're in is just caused by this overconsumption of the wrong food. I mean, we were able to, more consistently teach children at school, teach people to eat the right stuff. I mean, we would not be in the situation we're in right now. Right?
Exactly. I think, teleologically, we're built to be about 18 years old with a BMI of like 19 and like kind of struggling to find food and eating mostly vegetables and fruits. And the farther we get away from that, the more we get things like HFpEF and CKD and hypertension. So the more fuel coming in, the more fat, the more, and then of course getting older. Unfortunately, we're not built for that either. We're not built to be 70 years old. Fortunately, many of us can reach that, but that takes a toll on the body as well. So I think these are the targets, really. These are the ways that we can address HFpEF and all the other things that go with HFpEF, the CKM syndrome.
Oh, I think that's a great concluding remark, Barry. I don't think we can take more of your time. This is such an interesting discussion for all of us. I mean, we could be discussing on forever, really, and we're really delighted on your thoughts and remarks. Christoph, yours as well, of course, and you two interacting. So this has been great. Thank you so much for all these trials and for your input into the field and all the other things you've been doing. I also admit to really love your papers and your insights. And there's, I think, not so many people who really have been digging into the special mechanisms of fluid and hemodynamics of HFpEF, and we can learn a lot of that. And I learned a lot in this talk now in this past hour. So thank you very much indeed for your time and all the work you've been doing.
Thank you. It was a lot of fun.